Hi everyone, welcome to another Monty-Hart lecture. Today we have the great honor to have Dr. Alexander van Rosendael, who will be speaking about clinical implications of CT-guided plaque assessment. It's a real honor to have him today. We're closing actually this part of the year, so we'll have a gap for a couple months. So I couldn't imagine a better speaker to end this part of the year. So Dr. Van Rosendael is a cardiologist and specializes in non-invasive imaging of coronary artery disease, particularly through coronary CT. He earned his PhD for research conducted at the Leiden University Medical Center in the Netherlands and at the Weill Cornell Medicine Dalio Institute for Cardiovascular Imaging here in New York. He has participated in various international cardiac CT trials and is actively involved in research on AI-assisted automated coronary plaque imaging. Alongside his research, Dr. Van Rosendael is a member of both the European Society of Cardiology and also the section editor for cardiovascular CT at the International Journal of Cardiovascular Imaging. Thank you so much for joining us. We've been following your work for a while, so we're very happy to have you here.
Thank you very much for the introduction and also for the invitation to talk about this topic I really like to talk about. The disclosures, I will send another one with the disclosures. When you have a patient and you're looking for risk stratification of the patient, they usually you can do it based on clinical risk factors. That's how everybody does it. But now with all the evidence coming in, we learn more and more that actually it's an imprecise approach. It works, of course, it works well in general, but for your individual patient, it has limitations. For instance, from the MESA population cohort, you see, this is already a very old article, that actually only 20% of the events occur in the high risk group, and most events occur in those with intermediate risk category. And for instance, if you look in the patients with admitted with a myocardial infarction, only 80% of them had actually an abnormal cholesterol. Most had a normal cholesterol. So when you, from a pathophysiological point of view, when you look at coronary events, they're usually, like almost all, are caused by coronary atherosclerosis. And if you look at the coronary atherosclerosis, it risk stratifies very well, and you can do it in many ways. For instance, with IVUS, it works more plaque on IVUS, more events. And of course, with coronary CTA, it works very well. Before we had automated quantification of plaque, you can just do it by categorizing it according to stenosis, and the more the stenosis, the higher the events, and that risk stratifies really well. Normal CT has almost no events in the upcoming 10 years. And there is a little bit of data, small cohorts usually, where we already see that with quantification of plaque burden, it works also really well. So total plaque volume is a measure that I will talk a lot about it, and you're gonna hear a lot about it when it's about quantification of plaque. And that risk stratifies really well, more plaque, more events. And is it the plaque or is it the stenosis we need to look at? And there is this is four of the most recent large studies where you have a CT scan and the patients are followed for the events, and within the 0 to 5 years, the event occurs. And if you go back to that CT scan, you see that actually most of the patients with the event did not have obstructive coronary artery disease on their prior CT scan. Less than 50%, as you can see here, did have a more than 50% stenosis. So looking for the obstructive stenosis is good for your symptomatic patient, but it's not really gonna identify the patient that is really gonna have the heart attack. So I think we need to look at the plaque burden, at all the plaque throughout the coronary tree, and there is evidence that that works the best to combine it with stenosis. This is a very large cohort from Copenhagen, almost 10,000 asymptomatic individuals followed for over years. And there you see that there is an interplay between the burden of plaque and whether it's obstructive or non-obstructive. And also in this paper, you see actually that patients with extensive non-obstructive atherosclerosis have a similar risk as those with obstructive stenosis. So the amount of plaque together with the stenosis severity is where we need to look at. So you can do that, of course, by counting every plaque from all the 16 segments in the coronary tree. It's very time consuming and it's sometimes it's inaccurate. What's upcoming and what we have now is that you provide your CT scan for an automated quantification of plaque, and you get the magnitude of plaque by the software. And you can stage that plaque burden into several categories. As you can see here, this is a staging system that's already been published. So you have no plaque, which is stage 0. And here you have a little bit of plaque, then your stage 1 and your stage 2. And stage 3 is, for instance, this staging system, more than 750 cubic millimeters of plaque. And there are many of these plaque quantification softwares out there, and they are usually validated against IVUS, plaque volumes compared with IVUS, and these are from 3 of the largest software factors, and you can see that there is generally good to very good agreement with intravascular ultrasound. Of course, there is some scatter, but in general, there is very good agreement. Do we really need to look at the plaque burden to risk stratify your patient, or is it just good enough to look at the calcium? Like, the calcium score is so simple, it works so well, it risk stratifies your patient very good. I really like that test, but it has some limitations, why it's, I think, not as good as looking at the total amount of plaque. This is a study from, this is the ICONIC study, in which we had almost 240 patients who had a CT scan, and they were followed for events. And the events were all myocardial infarction. And when you take those 240 patients with myocardial infarction, you go back to the CT scan, and you have automated quantification of all that plaque. You see this figure here, where you have in the red the non-calcified plaque of that CT scan, in the yellow the calcified plaque, and here you see it according to the age. And if you look in those patients which got their myocardial infarction older than 80, you see they did have a lot of calcified plaque and even more non-calcified plaque. But especially in this younger group, where risk stratification is, I think, even more important, the patients less than 50 or 50 to 90, sorry, 50 to 60-year-old, they had only very little calcified plaque. In these less than 50, there was almost no calcified plaque. But on the other hand, they did have a lot of non-calcified plaque. So you can identify the risk of these patients, but only by doing a CCTA. Actually, in this group of patients who got their heart attack younger than 50, the calcium score was 0 in 50% of the patients. So calcium score works less good in patients younger than 60. You will underestimate the risk. And another thing is that calcium score is calculated by the volume multiplied by the density. So the more dense the calcium, it was always assumed that it was higher risk, but it's actually the inverse. So the calcium score will go up if your calcium becomes more dense. But in this study from the MESA, you see that here the density score, actually the higher the density, the lower the risk for events. And when you give your patients statins, or when the patients become older, the calcium will become more dense and the calcium score will go up, but actually that patient is getting a lower risk. So these are 2 important limitations of the calcium score. Is it enough to just look at the plaque burden to risk stratify your patient? It works really good, but it adds even more to look at the composition of plaque. And that question we wanted to investigate in this study, the ICONIC study. So in this study, we matched 234 patients who got a heart attack after the CT scan. We matched them with 234 patients who did not get a heart attack after the CT scan. And we matched them for age and gender and the site and the cardiovascular risk factors. And the most important matching criterion was to match them for the extent of the atherosclerosis. Because if you want to look at whether the composition of plaque adds to prognosis over the plaque burden, you need to have the same plaque burden, because plaque burden is much stronger predictor. So that's what we did in this study. And it turned out by this matching procedure that actually in the cases and the controls, the plaque volume was identical. But here you see that there is important differences in plaque composition. So when you look at the composition, here you have this necrotic core from the CT scan. It looks like this. It's this very dark plaque, less than 30 Hounsfield units. You see that type of plaque was actually higher in the patients who went on to develop a heart attack in the future. And it was the same for this fibrofatty plaque, which is a little bit less dark, but still dark. For the intermediate types of plaque, like the fibrous plaque or the low density calcium, it was identical, it was the same. But then what we also saw was that if you look in the calcium, the calcified plaque, but then especially the very high density calcified plaque, so the plaque more than 1,000 Hounsfield units, that was actually higher in the controls. So it's a sort of a protective plaque. It protects you from getting a heart attack is the hypothesis. And that's what we saw in this study. So what you also can do is serial CT. That also adds to your risk stratification. And there is already a lot of evidence with serial IVUS, and we've learned so much from that. There is these very large trials with statins and PCSK9 inhibitors where they saw what happened with the plaque. And basically what you saw with serial IVUS, here they always measure the percent atheroma volume. So the lower the on-treatment LDL, actually the lower the plaque regression occurs. You can regress the plaque when you do it with IVUS. And what you also saw in IVUS, that's especially the VH IVUS, the virtual histology IVUS, is that the lower the LDL is going to be, actually the higher the calcified component of the plaque is going to be. So lower LDL relates to more calcium. Actually, this was barely significant or just not significant. So IVUS is not the perfect test to look at calcium, but this is a trend you saw in IVUS. And we can also do serial CT, and there we have stronger results especially with plaque composition. So this is what happens when you do serial CT and you give statins. This is the Paradigm study. It's a registry of 1,200 patients, almost 2,500 lesions. Patients got the CT scan at baseline 4 years later. And when you look at the patients without statins and with statins, you saw that the annual change in percent atheroma volume, so the annual change in plaque burden, was a little bit slower in the patients who used statin. All patients progressed, as you can see. It was just a little bit slower in the statin group, but as you can see, it was not a lot. But where the difference is going to be with serial CT is in the plaque composition. So what you see is this is a case example. This is at baseline, and you treat the patient with a statin. You see the regression of the non-calcified plaque, and you see the increase of the calcified plaque. And this is exactly what we studied. So this is a difficult figure, but I will try to explain it. So this is the plaque volume at baseline. So here we compared lesions at baseline and lesions at follow-up. So no patients, but individual lesions. We matched them. And here you have the volume of the plaque at baseline. And here you see the change in necrotic core from baseline to follow-up. In the patients without statins, you saw there was an increase in necrotic core, but with statin use, there was a decrease. You saw the same for the fibrofatty plaque, so decrease in fibrofatty plaque with statin use and increase with no statin. Fibrous plaque was the same. And here again, if you look into the very dense calcium, so the calcium with very high Hounsfield units on CT scan, you actually saw that when you give a statin, those patients get more of this very high densely calcified plaque. So basically they transform their necrotic core and their fibrofatty tissue into highly densified calcified plaque. So this is a process that is associated with reduced risk. And how does it work into practice? This is a case report I took from the literature. It's a very nice case with 5 CT scans over the years. So this is a patient who got, this is an LAD in 2008. You see here a small lesion in the proximal LAD. The blue is the calcified plaque and the yellow is the non-calcified plaque. You see 1 year later, there was increase in especially the yellow, that's a non-calcified plaque. So what did this cardiologist? He started the patient on high dose atorvastatin and a PCSK9 inhibitor. And 4 years later, you see a total calcification of that lesion. All the yellow is gone, it's all blue, and blue is calcified plaque. And actually, that kept on staying the same. So this plaque it was totally calcified and it stayed that way over the course from 2008 to 2021. So this is all about the total burden of atherosclerosis from the entire coronary tree. But there is and has been a lot of focus on specific individual high-risk plaque lesions. And in the guidelines, they have been defined according to 4 high-risk plaque features, namely the positive remodeling index, the low attenuation plaque, the napkin ring sign, and the spotty calcification. So is that something we also need to look at? Do we need to look at these individual lesions and define whether the patient is high or low risk based on that? It works. This is a study from Dr. Ferencik. This was from the PROMISE study. It works in risk stratification. Here you see the 2 variables, the significant stenosis and the high-risk plaque. And you see here that if there is high-risk plaque, in addition to significant stenosis, it gives higher risk. And also patients without significant stenosis, but high-risk plaque, they are at higher risk. It works good, but a limitation of this study is that they did not take into account the whole burden of atherosclerosis from the tree, because this is only whether the patient had obstructive stenosis or not. And it could be that the results were non-significant if they took into account plaques from every segment. So this is another study with FFR-CT where you see that it's still that you still need to look at individual lesions. This is a very elegant registry, the Emerald-2, where they have 350,000 patients, where they all got a myocardial infarction and they identified the specific culprit lesion for that myocardial infarction. And the most predictive feature, lesion-specific feature, whether that lesion would become a culprit, was actually the delta of the FFR-CT over that lesion, as you can see here. But again, these were all lesion-specific measures, but still wondering what happens if you look into the total burden of atherosclerosis, whether then still it's important to look at these individual lesions. So this is results from the CONFIRM-2 registry that we presented at the TCT at the end of last year. This is one of the first registries, large cohorts with automated quantitative CT. And we have, at a registry, we have now about 3,500 patients from 80 sites over 13 countries. The patients were followed up for an average of 5 years. And all patients, all the CT scans were evaluated by AIQCT, so automated quantitative CT. And we looked at MACE, including death, myocardial infarction, stroke, heart failure, unstable engine, and late revascularization. And when you look at all these variables that automated quantitative CT it provides you, all the specific lesion and patient-specific variables, we saw that actually the 2 most predictive variables for MACE were the diameter stenosis, of course, not surprising, and the burden of the non-calcified plaque throughout that coronary tree. It was not a total plaque burden or the calcified plaque burden, it was specifically the non-calcified plaque volume burden. And those 2 were the strongest of all the others, as you can see here. And here you see that if you categorize these 2 variables, you see that you get very strong risk stratification. So patients with high-grade stenosis, lots of plaque, have 10% events, and patients within the lowest 1/3 of risk only had 1%. And you see much stronger risk stratification than, for instance, the Diamond Forrester risk score. And this is another analysis to look at prognostic accuracy of the two variables, the non-calcified plaque and the stenosis. If you look at the AUC of the Diamond-Forrester pretest likelihood together with the risk factors we all know, so smoking, hypertension, diabetes, dyslipidemia, family history, you get an AUC of 0.65 for the prediction of MACE. But when you add in the diameter stenosis and the non-calcified plaque burden, the AUC goes up to 0.77, so very significant. And this is actually a sub-study where we look in the differences between men and women. And we actually saw very interestingly that the risk of plaque from CT is actually higher in women than in men, especially in the highest amount of plaque. So usually women develop coronary artery disease 10 years later and they have fewer events. But this is women, this is men. But if you look at, this is the non-calcified plaque burden. So there is a stronger relationship between non-calcified plaque volume and events in women than in men. So it's maybe a CT scan is even more, you can even risk stratify women better than men with the CT scan. There is a lot of softwares for automate for plaque burden quantification, and what we actually need to know is what is a little plaque, what is a lot of plaque, what is normal for this patient, what is not normal, and this is all very new, and we don't know that very well. But this is one of the first normograms, as we have them, of course, for the calcium score. We have the normograms. This is one of the first for the total plaque volume. And here you see that, of course, according to age, the plaque volume goes up. This is one of the first studies where we have this important type of data. Of course, there are concerns. It's a very new field, and there are still significant concerns. What you need to take into account when we are going to apply it into clinical practice for your patient. First of all, as you probably all know, is that the kilovolt you provide to your CT scan, or also the attenuation of contrast in the aorta, it affects the composition of plaque. It does not affect the volume. So if you change your kV for your CT scan, usually the volume of plaque stays the same. But if you increase the kV, your amount of calcium will go down and your amount of non-calcified plaque will go up. So that is very important when you do serial CT studies, that you keep these the same, or you try to correct for that. But that is a very difficult process that I have not seen anyone provide a good solution for that. Also, when you read the literature, people report plaque in very different ways. Some only take the specific lesions and they multiply it, whether others take everything from the whole coronary tree and they sum that together. Of course, that's going to bring differences in total plaque volume. And also, this is a very important thing that you see in the literature now. There is a very large difference in magnitude of plaque between different softwares and studies. For instance, in the CONFIRM-2, we saw that the percent arterial volume was 2.2%. In the Scott Hart, it was 39%. And in another very large cohort of 11,000 patients, it was 9.1. Of course, these are different cohorts, different risk profiles of patients, but these differences are too large to only be explained by that. And it probably all has to do, to a certain extent, with the fact whether or not you include the vessel wall in your plaque magnitude. Because if you're going to include the vessel wall, your plaque volume is going to be much larger. Other also low attenuation plaque, very hot topic. It's the highest type of risk, but people define it in different ways. Some use 75 Hounsfield units as the upper threshold. Some use 30. Some use a threshold that's adapted for the Hounsfield unit of the contrast. It's also going to change the magnitude of that. And also what to do with the minimal amount of plaque. So when you have your patient, you give him a CT scan and he has only 10 cube millimeters of plaque. Is that patient at risk? Should he treat it? Or is that so little plaque that actually it's the same as a normal CT scan? Is the plaque you see just noise picked up by the AIQCT? So that's all things we still need to learn, but very important before you when you apply it for your patient. So this is a trial that's going on, a transform trial, because what to do with all this very good risk stratification that plaque burden can provide. You can guide your therapy based on these plaque stages. So that's what this transform trial does. So you define your patients into 4 groups. And of course, more plaque, higher the disease state, the higher the risk. So when you have no plaque, the advice is to take, for instance, only mild statin or metformin use. And when you go up into the plaque stage, you can give your patient all these new medications. We have these very strong, new, and also expensive, unfortunately, anti-atherosclerotic therapies, because these patients in stage 3, they are really high risk. They are probably similar or higher risk than your standard secondary prevention patient. And this study is looking whether treating that risk is also gonna improve patient outcomes. So this is another thing that this talk is not about, but also this plaque the plaque burden from the coronary tree. It also is a very strong surrogate for ischemia. It predicts ischemia very well. This is a case. There is a LAD with of course a very high lumen narrowing with plaque. And when you combine all these plaque features together, you can get an AI QCT ischemia algorithm, and that predict that this lesion is ischemic. And how this algorithm got developed? It was based on a cohort of 612 patients, all having CT and invasive FFR. And they all got the fully automated quantification of plaque. And based on 22 variables, as you can see here, an algorithm was developed that's going to predict whether that lesion is going to be ischemic or not. And here you see the machine learning feature ranking. And as you can see, of course, the most strong predictor was diameter stenosis, but also the lumen volume is an important predictor. The total plaque volume is an important predictor. A remodeling index, it all adds a little bit in your prediction whether that lesion whether that vessel is going to be ischemic or not. And as you can see, this actually works very well compared with FFRCT or PET imaging, and much better than SPECT imaging. So in conclusion, coronary artery disease extent by CCTA is very strong predictor for MACE, and it's a much stronger predictor than cardiovascular risk factors and stenosis severity only. By doing CT, we go away from very strict difference between primary and secondary prevention, because the patients with a lot of plaque are, in my opinion, they are sort of a secondary prevention patient. Scott Hart's study, I didn't mention it here, is the trial that showed that treating your plaque burden on CT is really gonna reduce MACE. Quantitative CT provides incremental value above visual reporting of atherosclerosis, although that needs still more validation. There is little evidence about that. We have low attenuation plaque and very dense calcium on CT, and this very dense calcium is lower risk than this very low attenuation plaque. And trials are currently ongoing to look at whether applying your anti-atherosclerotic therapy intensity based on the coronary artery disease intensity is really going to benefit your patient. Thank you.
Thank you so much, Alex. That was wonderful. Obviously, I love the topic, but also how you presented the data, I think was very clear and very promising. So for everyone, please put your questions in the Q&A chat and we'll go through them. I'll start with one myself. I mean, obviously, CT-guided approach is way better than clinical risk factors, as you showed and as we all know. And we know the caveats of calcium score, but still a CCTA approach is not recommended by guidelines, and we're not doing it in our clinical practice as of now. So what do you think is needed to bridge that gap into getting us there? Is it the transform, or we need more studies? What do you think?
Yeah, you mean especially, I think, for the asymptomatic patient individuals, right? Yeah. Yeah, it is. We need more data that you really get. Yeah, the limitation is that there is so few outcome trials that you're really gonna change your outcome based on the CT scan. Of course, there is this called HEART, but it's one of the few. There is a Scott Hart 2 ongoing, which is exactly looking at this question you asked. They're screening with coronary CT and treating based on that CT scan. Transform is also looking at asymptomatic individuals, treating based on the CT plaque burden. So I hope that these trials are gonna bring the answer. And yeah, that's what I hope. And yeah, my opinion, calcium score is a good test. CT is just better. And for some patients, maybe calcium score is enough. That's all you want to know. But for younger patients, CT angio is of it provides you much more information. But of course, you need to give contrast. It's more cumbersome. But the radiation is actually almost the same. So that's not any discussion point anymore.
So true. Yeah, the radiation is almost the same, and hopefully the cost will be similar. We did this ASPC, imaging symposium online, and in some places people are already treating, doing CCTA for follow-up and adjusting therapies, some experts. So it's guidelines are always late, but how fast we approach this and how much data we need, I think is different for different people, right?
Yeah, for me, it's also very interesting to hear your experience from the US because I'm in the Netherlands and I treat there. And usually we're a little bit more conservative in the US. Like that case report, it's not something I would see very easily in the Netherlands. But yeah, I think in the US, people are some sites are very much more provocative, much more going on forward. Yeah.
Yeah, and so we were just in Beijing in a work trip giving lectures, and some people are saying China, even the government is approving CCTA for asymptomatic if you have risk factors, and they're using it,
Oh,
population based.
oh wow.
Yeah,
Wow.
some
Yeah. So,
different practices. So we have a question from Daniel Lorenzati. He says, awesome lecture. For confirm two, did you examine the individual components of the primary outcome? And then he says, which AI QCT features were most predictive of MI after adjustment?
yeah, because indeed the primary endpoint included also late revascularization, heart failure, especially late revascularization. It took 50% of the outcomes. But we saw actually similar results when you restrict to death and myocardial infarction. Unfortunately, we don't have death specific. It's so hard to get, like we don't have cardiac death, but just all-cause mortality. But when you look at the hardest type of events, all-cause death and myocardial infarction together, you see actually similar results. You see the AUC is the same, the hazard ratios are the same. So that was very reassuring for me that that was similar. Yeah.
Thank you very
Also the
much.
non-calcified plaque. Yeah.
We have another question from Daniel. He says, in your opinion, which metric better reflects plaque burden? Percent atheroma volume or absolute plaque volume?
Oh, that's a really interesting question from an expert because I think that we don't know that answer actually yet. I think what you see now is usually people report the PAV, the percent atheroma volume, similar to IVUS. What is good on that is the benefit is that, for instance, if you cannot evaluate the whole vessel, especially if there is a vessel diseased, you would exclude it, and maybe your total plaque volume would go down, but your PAV would stay the same because also your vessel volume becomes smaller. So for vessels where you cannot, patients where you cannot evaluate the whole CT scan, that's probably better. Yeah, I think it's a question it's not answered yet. There is probably in very large patients with a large BSA who inherently have larger vessel volumes, there is going to be discrepancy between plaque volume and PAV. From the data from the confirm 2, we are looking into this now. Where is going to be the difference, which is more prognostic? That's what we're looking at now. But I personally think this answer is not this is not answered yet. A limitation of PAV also is, let's say your nitroglycerin you give didn't work so well, or something was with it that the patient didn't respond to the nitroglycerin. So that in that case, your PAV will go up because usually your vessel becomes larger, your vessel volume becomes larger, and because your PAV is divided by vessel volume, then your percent normal volume be lower. So that could be that PAV is a less stable measure than plaque volume. So I hope this answers your question.
Yeah, 100%. And I think where he was going to is when I think it's very needed, and you put it in your lecture also to create stages. Because if
Yeah.
we only report these things, it's impossible for a practitioner that is not specialized in this topic of research to know what to do. But the question is, when you have different components that are at different stages, which one takes priority? And you didn't talk about PCAT or Phi, but what are your thoughts on that versus plaque?
Yeah, I think it can be an extra risk stratifier in addition to plaque. I personally think that you need to start with the plaque because it's so predictive and it also makes sense. I personally don't believe that if you have a lot of plaque and your PCAT is normal, that you're still low risk. I don't think that. But it can be that it adds to it. I saw very nice case reports of patients with no or little plaque and very inflamed vessels that they went on having a heart attack. So I think it needs much more study, and it's very promising. But I think you should for sure look at it together. I don't think you should look at it on itself.
On its own, yeah. Hopefully, we'll have some of these softwares will provide us with AI kind of geared, analysis on how far from normal each of those are and try to help a little bit because it's going to be hard otherwise to change practice, right?
Yeah, 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 yeah.
If you want to stop sharing your screen, we'll share with everyone the code for CME.
Yeah. Let's see. Stop. Oh, there, stop share. Yeah.
Perfect. Lenis, if you want to share it there. I think while she shares that, I'll ask one more question. We have obviously a race of multiple softwares running, doing similar analysis of plaque. Uh, what do you foresee that is going to happen? You think they will merge, or people will just use like CTs, different ones?
Yeah, this is a very important question also. We need to get aligned in that. Like the what I showed is these very large differences in plaque burden. It's like as a physician and not expert, you don't know what to do with that. So there need to be a guideline recommendation or a consensus statement on how we should do this. Yeah, that's very important before you can do individual like inter software comparisons. Yeah,
100%.
yeah,
Perfect. Yeah. So thank you very much. That was wonderful. So hopefully the weather gets better there and you get to enjoy your weekend.
yeah. Thanks a lot for the invitation, and I hope the weather gets better there too. And have a nice weekend.
You too. Bye bye.
Bye.
See you.